I have mentioned in the beginning of my lecture that the treatment outcomes of traditional implantology are not predictable at all. And what is also unfortunate is that many patients are excluded from treatment, so this should give us the incentive to look out for something new, to change our treatment modalities, to use other implants, to use other strategies. And we have to work and look out and utilize real alternatives. And from my experience, I'm working with this now more than 16 years, basal implantology is a very predictable technology, it's easy to apply, and it solves all four major problems of conventional dental implantology, including the major problem of periodontitis. Thank you very much for your attention.
Dr. Ihde, thank you very much for your lecture. We have heard about this type of setting implants in the last few years. I can tell you it's not a traditional method to set implants, it's a novel method, and it's, as you've mentioned in the very early part of your lecture, it's a wide discussed method among Hungarian colleagues, and I'm a little bit pessimistic what time it will need to skip those terms from implantology, like implant, the importance of the surface of the implant, or healing time, or bone augmentation, so it will take a lot of time. But if your system is working in your patients, I don't know how many patients, how many colleagues will use this system in Hungary, or do we have a number? Okay, many patients.
I think for Hungarian dentists it's a very important system, because as far as I understand, the country is specializing on dental tourism. So those dental tourists, of course, they want to do their tourism next year to some other place, not again to Hungary. And so you need something that you need implants which you can load immediately, where you can deliver the bridges. And as far as I understand from those doctors which I have trained, most of the patients which they treat are of course foreigners, are Austrians, Germans and Russians. So they come here, they come for a week or 10 days, and then they just go home. And maybe this is why in your local patients you don't see so many of these implants, but they all sit in the airplanes and go.
You mentioned that there are a lot of theories and only a few facts in implantology. Who decided that your system is a theory or a fact? Only the patients, or?
Yes, the patients. The patients, yeah. As long as you leave the choice to the patients, they will take a clear decision.
If somebody has a question or comment?
Answering all questions, scientific, non-scientific. Yes, please.
Ha ennyire hajlékony az implantátum fejt, akkor mennyire miért tudja így biztosan tartani a villamost?
Yeah, the word. Maybe the word flexible. You translated it right? No, I think you should use the word plastic deformation. What we do is we are creating a plastic deformation. We are not like bending, flexing the implant around, but the implant is stable in the second cortical, and then we just make a plastic deformation of the head. This is a 2 millimeter titanium alloy implant body, and you can simply bend it. You cannot bend it this and this and this, it will break, but you can create a plastic deformation, create parallelity this way, and of course you cannot do it always, because for example, some bone areas in the maxilla, they are not strong enough to withstand those forces. So in this case you have to use angulation adapters, cementable angulation adapters. The implants are rigidly integrated in the cortical. There's no vibrointegration, elasticity. This is really rigid. If it's not rigid, we don't start with prosthetics. It's changed.
Yes. I have one more question. You mentioned that if you clean or if you treat the surface of the implants or screws with betadine, you can not only diminish the number of germs, but you can exclude them.
Yes.
It means sterilization. But in the oral cavity, you cannot reach sterilization, only disinfection. So they cannot be sterile.
The term sterility is defined as the absence of a live bacteria, of any live microorganisms. And if you, it depends how you do it, but if you, for example, would work in full anesthesia, with an intubated patient, but the patient is intubated through the nose, then the throat is stuffed, and then typically you would open the mouth, you would insert 10, 15, 20 ml of betadine, and close the mouth, tape it, go out to drink the coffee, and come back, and after this you work in a sterile environment, because nothing is alive.
The opinion is that you can sterilize the surface of the oral cavity free from bacteria.
Everything which is accessible to the betadine will be taken. Maybe in the tonsils or in some crypts of the tongue, something might be left over. But everything, all the surfaces which are accessible, nothing will be there.
That is about from microbiological studies. You will submit your opinion that it is a good study for us. Okay. Thank you so much. Other questions?
Azt szeretném kérdezni, hogy elvileg ez a 4 vékony kis 2 mm-es pálcika el szokott-e neki törni az idő folyamán?
You see the dimension of the implants. Of course, we have approximated to an optimum dimension, and we had fractures in the end of the last century, in the beginning of that century. But for the basal implants, then we kind of changed the design of the base plate. Before, the base plates were simply horizontal, and now we have this kind of curvature. And since then, the base plates don't fracture anymore. We have seen fractures, and of course, one answer to avoid fracture is to put more implants to distribute the forces. But I personally prefer to use this strategic implant placement, so to put implants on the 7, the 3, the 7, and so I see today with today's designs, I don't see any problem with fractures. Anyway, the BCS don't fracture. These screwable, they don't fracture. Under normal conditions, the normal condition is that the bridge is fixed to the implant with Fuji or some reliable cement. As soon as you have a bridge on 10 implants or 12 implants, it is only fixed on 2 implants anymore because the cement became loose, of course, this will fracture. But the normal conditions, which means there is no fractures.
Még azt, hogy milyen anyagból vannak el az implantátumok?
The BOI is titanium grade 2, and the CS is titanium 6, aluminium 4 vanadium. That's implantable titanium alloy. I mean, like most of the implants are. You shouldn't be too worried about the fractures. I mean, if you're worried about fractures, look at the 2-stage implants and look at the cross-section of the 2-stage implants. There's almost no titanium. I mean, because it's hollow. There's a drilling, there's a thread. So this makes me more worried.
Is it easy to get it out if it's fractured? Is it easy to get it out?
The implant?
Yeah.
Well, if it's integrated, I wouldn't get it out. I mean, just leave it in. If you need another one, you just place the BCS next to it, place another one. Yeah, or re-cement the bridge, simply, and don't. If you have 10 implants and 1 fractures because the bridge was loose, then unless it's a strategic implant, then of course, if it's a strategic one, you have to replace it. There's no choice. But all those filled up implants in between, if they fracture, you can live without them.
Szépen szeretném megköszönni még egyszer az előadást.